Now, which are the patients, which subset of patients require MRSA therapy? So in 2016, they recommended that a patient who has sepsis or septic shock at high risk of MRSA, antimicrobial therapy included one or more antimicrobials along with full coverage of MRSA with fungal or viral coverage. But in the 2021, they suggested that a patient who has low risk of MRSA should not be given a MRSA coverage. Although in India we have less incidence of MRSA, it is more common in European countries and in the Western countries. MRSA approximately comes in around 5% of culture positive infections. There are various subset of patients in whom MRSA can be quite prominent, especially if there is a previous MRSA infection or colonization, recent use of IV antibiotics, history of recurrent skin infections or chronic wounds, as may occur in diabetic patients or patients with peripheral vascular disease, Raynaud's disease, patients who have invasive devices within them, who are on hemodialysis, who had recent hospital admissions, or if they are very sick. Because if they are very sick, there is high probability that they'll be having number of invasive lines, which will increase their risk of having colonization or infection with MRSA. So in patients with sepsis or septic shock who have at high risk for MDR organism, MDR means multi-drug resistant organism, septic guidelines recommend 2 antimicrobials with gram-negative coverage over 1 gram positive agent. In patients who have low risk of MDR infections, they should have 2 gram negative instead of just 1. In patients, this will become too confusing for you. So, how do you say that the patient is at risk for developing an MDR infection or he is not at risk for MDR infection? So MDR infection means multi-drug resistance. So they are resistant to multiple drugs. So what are, if they have previous infection or colonization with these organisms, that is MDR organisms, within the last 1 year, then they are at high risk for developing it again. Now your local antibiogram, which means the local prevalence of the antibiotic resistant organisms, that gives you a lot of help in deciding whether you are dealing with an MDR or a non-MDR patient. Hospital acquired infections or healthcare associated infections, they are usually MDRs. Broad spectrum antibiotic usage in preceding 90 days. So if you have already used broad spectrum antibiotics, there is a high probability that the patient will be infected with MDR. Now, concurrent use of SDD, that is selective digestive decontamination. Travel to a highly endemic country within the last 3 months or hospitalization within the last 3 months. These are all high risk for developing an MDR infection. So we have covered antibacterial gram-negative therapy, gram-positive therapy. Now coming to antifungal therapy. Now, in patients who are in sepsis or shock with high risk of fungal infections, antifungals should be used. In patients who are at low risk of fungal infections, it shouldn't be used. Now, who are the patients who are at high risk for developing fungal infections? So risk factors for Candida sepsis. Candida is the most common species which we encounter day in and out. And one is Candida albicans and the others are Candida non-albicans. So risk factors for Candida species is if there is Candida colonization at multiple sites, Multiple site means you may have a dialysis catheter in the intrajugular vein, or you have a Foley's. So they both are growing candida. So this patient is at high risk for developing invasive candidiasis. Surrogate markers like beta glucan. If a patient is neutropenic, he is getting immunosuppressive drugs. The severity of infection is high. That is, he has high Apache score, prolonged ICU stay. Other invasive vascular devices are there. For people who inject drugs, a very important thing for developing risk factor for developing fungal infections is TPN, that is total parenteral nutrition. Patients who have received broad spectrum antibiotics, patients who have GI perforations and anastomotic leaks, patients who underwent gastrointestinal or hepatobiliary surgeries, acute renal failure or patients on hemodialysis, several severe thermal injuries, prior surgery. So these are the risk factors for Candida species. Now, for Cryptococcus, histoplasma, mostly HIV, solid organ transplant therapy, solid organ transplant, patients who have bone marrow transplant, patients who have been on very high steroid therapy for a long time, patients of diabetes. So this is a Candida score on which we decide whether the patient is at risk or not. Includes 4 factors: surgery, which is given the score 1, multifocal colonization, total parenteral nutrition, all given a score of 1. If the patient is in severe sepsis, it is given a score of 2. Cutoff value of 2.5 has a sensitivity of 81% and specificity of 74%. So antiviral therapy. We are already covered antibacterials and antifungals. Antiviral agents have no role in sepsis or severe septic shock. Now, we have already decided upon the antibiotics. Now, route we all know is IV only. But in patients who are in sepsis or shock, prolonged infusion of beta-lactams, because beta-lactams are usually given in gram-negative bacterial infections. So infusion over prolonged time over a conventional bolus regime helps in maintaining their concentrations, which align with the pharmacodynamics of these drugs. So the drug levels which are achieved in the blood are much higher and consistent as compared to when you give just a bolus dose. So administration by prolonged infusion, either by extended infusion, or that is at least for 2-3 hours, or a continuous infusion, results in sustained levels. A loading dose before the antibiotic, before prolonged infusion, avoid delays in achieving their concentration. Now, pharmacokinetics and dynamics, I'm sure you all are aware. So there are some conditions in which these antibiotics need modification, like in augmented renal clearance, in patients with acute kidney injury, hypobilirubinemia, in patients on renal replacement therapy or on ECMO. There are these scenarios in which all these therapies affect the concentration of the antibiotics, and you may need to modify your drug dosing accordingly. So this is some PKPD of drug classes. I'm sure you must all be aware of. So next is, after you have given the antibiotics, you have started antibiotics. If they are at high risk of developing fungal infections with Candida spore, you have already started antifungal. Now, unless and until you do a source control, you are not going to treat the sepsis. You're just controlling it, but you have to remove the source. So rapidly identifying and excluding a specific anatomical diagnosis with infection is recommended. Foci of infection may be intra-abdominal abscess, gastrointestinal perforation, ischemic bowel, volvulus, cholangitis, cholecystitis, pyelonephritis. It can be anywhere, anywhere. So all these infections in abdomen or in deep space, they should be readily, these sources should be readily controlled by drainage, operating, pigtails, anything, whatever you feel safe in your patient or what is recommended. So if a patient is having an infection because of some intravascular device, you need, and you are suspecting that this is a most likely the source, you need to remove it as soon as possible, because these unless and until you do the source control, you are not going to treat your patient. So but in cases where there is no shock or there is no fungal infection, some implanted tunnel catheters, they can be also treated effectively with prolonged antimicrobial therapy, especially in cases where it is not possible to remove the catheter. Now we have already given antibiotics. What about when do you start thinking needs to now stop the antibiotics? So for de-escalation of antibiotics, daily assessment is necessary, which means you need to know the drug dosing for how many days you need to give it, and you need to daily assess whether you are giving some antibiotic empirically or you have some culture positivity report. Now, these are some planned duration of antibiotic therapy, in which there were some random control trials which compared whether short duration of therapy is better or long duration. So they found out that shorter duration of therapy was equally effective along with adequate source control over the long duration of antimicrobial therapy. So now what are the biomarkers to discontinue antibiotics? So the biomarkers, as I already told you, procalcitonin should be used for de-escalation of antibiotics. So procalcitonin along with clinical evaluation, both in combination should be used to evaluate whether you can discontinue antimicrobials or you cannot. If your patient is improving, but your and procalcitonin is still high, so you will again reassess. But if your patient is clinically improving, your procalcitonin is already severely decreasing, so you can probably de-escalate the antibiotics. Now, in patients, we have already discussed about early goal-directed therapy of fluid resuscitation, where I told you that a crystalloid of 30 ml per kg should be used. So, septic guidelines recommend use of crystalloids as first line of fluid resuscitation. These should be balanced crystalloids. Albumin should be used in patients who are in sepsis or shock, who have already received large volume of crystalloids over using crystalloids alone. That means patients who have high requirement of crystalloids should be given crystalloids plus albumin instead of only crystalloids. Because if you give only crystalloids, they will cause third spacing and then lead to various other problems in your after your resuscitation phase is over, then in patients who are given albumin. In patients who are in sepsis or shock, starch, dextran, gelatin, they have no role. They should not be used. Now, these were the major trials of the fluid therapy. Starch, albumin, this was the chest crystal trial, success trial. So in success trial, patients who with severe sepsis who received fluid resuscitation with HES as compared to those who received ringer acetate had high risk of death and were most likely to receive renal replacement therapy and had few days alive without renal replacement therapy. So not recommended. So this shows that there was increased mortality and incidence of acute kidney injury. Same was the case with other trials also. So this was, which was published in NEJM. In patients with severe sepsis, albumin replacement in addition to crystalloids, as compared to crystalloids alone, it did not improve the rate of survival. It only decreased the need for the fluid, how much fluid you gave. So now you have adequately resuscitated the patient, but still the blood pressure is low. So they recommended that norepinephrine should be the first drug of choice over other vasopressors. In areas where norepinephrine is not available, you can use epinephrine or dopamine, but epinephrine should be preferred. Now, in patients who even on norepinephrine, their MAP is still inadequate. So they recommended use of vasopressin. So vasopressin was usually started when norepinephrine is in the dose of 0.25 to 0.5 microgram per kg per hour. In patients who are already on norepinephrine and vasopressin, still having low MAP, you can use epinephrine. Terlipressin should not be used because it is a very it is not a very good vasoconstrictor. So this was a study which was done in 5 ICUs in US, isotonic salines and major adverse renal event trial, that is the SMART trial. So they just had a multicentric, single-centric, pragmatic, unblinded trial between NS and balanced crystalloids. This trial showed no difference between the mortality between plasmalyte and NSCL. So the SMART trial, it showed reduction in the composite outcome of death and renal replacement therapy and renal dysfunction at 30 days with crystalloid use. And the split trial in 2015, it compared plasmalyte to NSCL. There was no difference in the primary outcome of proportion of patients with acute kidney injury. Although it is not statistically significant, this point estimates favored plasmalyte with regards to secondary outcomes of RRT. So already told you, first vasopressor to be used is norepinephrine, second is vasopressin, and third is epinephrine. If there is cardiac dysfunction with persistent hypoperfusion, then you can add dobutamine also instead of epinephrine. So this was comparison of dopamine and norepinephrine in treatment of shock, which was published in 2010 in NEJM. It showed that norepinephrine is better in achieving MAP as compared to dopamine. This was random controlled trials, which showed no mortality difference between using of various drugs.